have one of our visiting professors here this morning. It's a great privilege to have Dr. Michael Rotondo, who's the chair of surgery.
It was a fantastic day yesterday, I must tell you. I need not remind this group of the storied history of trauma care in San Diego. Those of us who grew up in the 80s in surgery and evolved their careers through the early 90s went to the literature and read papers written by people from this city to learn what we needed to do in a whole array of areas: trauma system development, trauma-centered development, outcomes management, work out of the basic science lab and resuscitation. It was great to see the hospital downtown last week. And to understand really the evolutionary track that this city has been on in healthcare in general and in trauma care in particular. It's been a fascinating story to watch. Today, this morning, will be, I hope, a painless exercise in listening to a story. It's not really a discussion of the science of damage control, of which still I'm unclear if there's an awful lot of science in damage control. There's a lot of art in damage control, but it's really a story of change. And I realized in thinking about introductory comments today that the discussion we had last night at the San Diego Society of General Surgery was similar, a story of change. This story of damage control is farther down the track than the story of the evolution of acute care surgery as the next logical step in trauma and critical care and emergency surgery development. And so bear with me as you hear my own personal reflections and reminiscences of how this whole thing called damage control, which is an idea or a concept, evolved through the late 1980s and early 1990s. And these concepts are not owned, ideas are free, and they evolve because of a whole number of forces. And again, similar to last night's discussion on acute care surgery, talk about some of those forces. But first, of course, my thanks to the Department of Surgery here at UCSD and to Dr. Talamini for his kind invitation, and to my host, Raul Coimbra, who's been phenomenal the last day. Really over the top in his hospitality, and it's very much appreciated. Now, Raul, as you know, has this fantastic team that he has just reassembled. You know this picture probably better than I. Found this noodling around on the internet in preparation for this. And he is really the new face of trauma and critical care for this instance, an old new face, right? And comes really from now a long line, Dr. Shackford, Dr. Hoyt, and now Dr. Coimbra, building this, continuing to build this phenomenal program. And some of the things that he's doing in terms of a multidisciplinary effort and bringing people together around injury care, around critical care and emergency care is really very, very important. I was most impressed with the faculty that I met yesterday. The residents did a superb job in their presentations. You can tell that the institution has a culture of trauma. That's a very important concept for those of us who work in the field, and that there's great dedication to the mission here for taking care of injured patients. What most of you might not realize is there appears to be another side to this surface. With just a little work on the internet, we were able to sort of come up with this convivial group working together. The UCSD trauma team. So again, my thanks to all of you for this great opportunity, and I hope that you'll find this morning's discussion entertaining, if not informative. I have to tell you a little bit about my own career, if I may, if you'll indulge me, in the place that I work, so that you can hear in part the context in which I'm going to talk about damage control, and it gives me a chance to tell you about my place, as it were. I was at the University of Pennsylvania for 10 years as a fellow for a year, as the first fellow in trauma and surgical critical care with Bill Schwab. I came over from the rival institution, from Thomas Jefferson University, the Department of Samuel D. Gross, and moved over to the Department of D. Hayes Agnew, both of them over a couple of hundred years old, 20 blocks apart, but worlds apart in how they thought about things. And when I left Penn, it was maybe even equally shocking to some as it was for me to go to Penn after Jefferson, because I moved down to the eastern part of North Carolina, from a major metropolitan area in the Delaware Valley, from Philadelphia down to a small town of 70,000 with a very different geography and a very, very different sort of healthcare environment, if you will. Here's the state of North Carolina. It's the right coast, I guess, right? And I live in this coastal plain, the eastern third. The state of North Carolina is divided up quite neatly into thirds. An eastern third, a middle third, and a western third. And they each have their own culture and their own feel and just a little different accent as well. You can hear how deep my southern accent has become over the last 8 or 9 years. In fact, the eastern part of the state was very insular for almost 100 years in its history. When North Carolina was considering seceding from the Union, eastern North Carolina was considering seceding from North Carolina. And it's this low, flat coastal plain with a subtropical climate where it gets hot and steamy in the afternoon and then a deluge of rain, and then the sun comes out in sort of a prehistoric fashion, and the moisture steams off. Most of the economic resources ended up in the Piedmont, in the central part of the state of North Carolina, where the evil empire, Duke, Chapel Hill, exist. In fact, a phenomenal research and development area that has just grown dramatically. The terrain gets a little more hilly, the climate gets a little more cooler, and the barbecue starts to change just a little bit as well. Even the food products change. And then out in the west, where the mountains, the Appalachian Mountains, are very much a mountain culture. And the barbecue changes again. It gets even more tomatoey and a little more smoky. And of course, a tremendous amount of folk art and folk music and a rich culture in that area. It's really been an interesting state. I've become an expert in North Carolina through my 3 children taking NC history when they were in 8th grade. So you get to learn about the history of your state through the kids. Here is Greenville, North Carolina, that sits in the middle of this area. The eastern coastal plain is actually bigger than the state of New Hampshire. About 1.4 million people, 29 counties. There are 19 other hospitals in addition to us. We're really the only tertiary care referral center that exists there. We go all the way out to the water, all the way up to the Virginia border, down to Wilmington, which is off the map, and then, of course, over to the Triangle, with the demarcating line being 95. Everything east of that, for good or the bad, ends up coming to our center. The hospital is associated through affiliation agreement with East Carolina University and the Brody School of Medicine. East Carolina University, gaining some notoriety over the last few years for its football team, has a superb school of music. It started out as a teacher's college, a very small teacher's college, which was primarily had women students, which has grown from a small number to now over 25,000 students. It is in the state of North Carolina system, the UNC system, so we in Chapel Hill, that is University of North Carolina, Chapel Hill, UNC Asheville, we all stay in the same system. It has a superb music school, which has been primarily focused on education, but we have great performance there. You literally can leave your house at 10 after 7 and arrive and park for free at 7:20 and walk in and see Yo-Yo Ma on stage at Greenville. It's a little unusual and unique in that regard. A stylized picture of the Brody School of Medicine. I use that because the building actually looks like it's been designed with early Leavenworth. It's not exactly a pretty building. The school rose up literally out of a tobacco field about 30 years ago as a primary care school. We're top 10 ranked in family medicine as well as in primary care, U.S. News and World Report. And we have about 80-some students a year with a focus on primary care and a focus on serving the underserved. And, of course, we have special accommodations for minority and disadvantaged students. So very different mission than University of Pennsylvania, where I spent the early part of my career. This is the hospital. It's sort of I like to call it a ranch-style hospital. There's the medical school sitting over there. It's low and flat. The water table is high, and there are, believe it or not, 762 beds at this facility. Not on the picture is a brand new cardiovascular institute that we're building, a cardiovascular hospital, a cardiovascular institute. Those are springing up out of the ground now. And we do, out of these 26 operating rooms, over 30,000 operations a year. About 90,000 emergency departments visits, 3,000 trauma visits. It is a busy place. 3 helicopters, 22 ground units, and that whole zone, the eastern part of the state, is our responsibility. The disease that we see is advanced. The disease that we see is severe. And it is clearly an underserved market. Just 4 hours from the nation's capital, some of the things that I see on a regular basis you would find very surprising in terms of the advanced nature of GI disease, the advanced nature of oncologic disease. It's phenomenal how the variations in healthcare across the country. The department was started by this man, Walter Porres, who's considered the father of American bariatric surgery. Even as recently as a couple of weeks ago at the Halstead, Walter's name was mentioned as a potential Nobel Prize winner for the work that's now evolving in the resolution of type 2 diabetes with morbid obesity procedures. He still has, at age 77, a tremendously active basic science, clinical and translational research laboratories. He is still a vibrant member of the department and clearly an important advisor for me. If you look in surgery, you'll see his cartoons. He's also an artist and cartoonist and really a really innovative Renaissance man. Our second chairman was Randy Chitwood. This is the individual who recruited me. Randy is an indefatigable innovator. Some would say the father of American robotic surgery, a very important issue for, I know, this institution. Randy has done some of the most innovative and creative cardiac surgery operations with using the robot with a large series of patients looking at valve replacement. And this is when Randy was able to work with our then Vice Chancellor, our Chancellor of the University and Governor of the state to get the state funding to build the new heart hospital and the Cardiovascular Institute, sort of a tripartite partnership, if you will, between the state of North Carolina putting in money, the university and the medical school putting in money, and the health system putting in money. A phenomenal photographer and an artist in his own right, a great medical historian and surgical historian, a couple of really tough acts to follow, I can tell you. This is the outline of the department. You may find it interesting that Dr. Chitwood was determined almost 4 years ago that cardiovascular surgery, cardiology would come together to form a new department. That has now come to pass. They'll be sort of opening their doors virtually within about a week, and we've worked hard to bring all of these specialists together in a new department around our #1 problem in the eastern part of the state, and that is cardiovascular disease and its sequelae. You can see our other divisions that we have, endocrine, minimally invasive, and bariatric surgery, and the Metabolic Institute, which is part of that. That's part of the Diabetes Obesity Center. This was the job that I was brought in '99 to take on and to build this center. We've just hired a new chief of surgical oncology. We do renal transplantation, but not multi-organ transplantation. A rebuilding plastics and reconstructive surgery division with a new chief there looking for recruits. A leading edge division of clinical effectiveness, which we created about 2 years ago. We've now have nice interfaces between NSQIP, NTRACS, the SRC database and the STS database. So this is where all of our quality management occurs in our preparation for pay for performance, as well as maintenance of certification. A brand new division of surgical education with a PhD surgical educator, and a number of strategic alliances which have now formed in the division. I have a division of surgery at 3 of the outlying hospitals, and I can see us over time growing that regional effort in eastern North Carolina, try to do our best to regionalize the care and meet our responsibilities. So that's the size of the department, and you would think that the sleepy little place out in the middle of nowhere wouldn't be doing very much, but I think you would be very surprised to see the level of activity. I was fortunate over my first really 4 or 5 years there to build this phenomenal team, and to be able to work with these people in trauma and surgical critical care. And then, of course, as luck would have it, my own responsibilities evolved to the point where we're now trying to have that same level of growth and energy across the department. So thank you for bearing with me a little bit. I wanted you at least to hear a little bit about the department. We'll take the next 30 minutes or so, 40 minutes, and talk about this concept, the concept of damage control. And I'm entitled to talk Damage Control, Revolution, and Rejuvenation, and I gave the first version of this at the Halstead Society and shared it with my colleagues there. And it really is an attempt to try to put the development of damage control into the context of the development, the historical development in surgery over the last 15 years. Picture for a moment, if you will, crouching down behind a barrier. You look down at the street and you see a chair leg, and you pick it up and it's got just the right weight, feels well balanced in your hand. And as you're there, you have a certain level of frustration that begins to arise. And you realize that it's the time to act. No longer can you simply stand by quietly and do the same thing that you've done over and over again. Something has to change. You've got to do something to make things be different than otherwise what they were. Anybody recognize the storming of the Bastille? Yes. Really a revolutionary historical event that has been studied really now for decades, if not, I guess, centuries, really. And if you look at what the environmental forces were for change over that period of time, they're listed here. Resentment of royal absolutism. In essence, there was a rejection of dogma that occurred. The low-wage earners and the peasants had a resentment for the hierarchical system that existed. There was also the age of the rise of enlightenment. People were going to be able to realize that certain principles were not being met. There was unmanageable debt, there was inequitable taxation, food was even scarce. Clearly there was frustration over what seemed to be really a stagnant and unchanging environment. It requires that kind of multi-vectoral force for change to occur in anything, quite truthfully, and lead to this sort of thing. Revolution, here's a definition: a total or radical change. A revolution is in one's circumstances, or a revolution in one's thinking. A drastic and far-reaching change in ways of thinking and behaving. One definition of revolution. Well, let's think about that, if we can, in the context of the changes that went on in the approach to trauma care through the 1980s and what led to it. What was going on in the 1980s? You know, it was the time of, big hair, Bon Jovi, and the Boss, right? Bruce Springsteen was reigning supreme. This was the sort of hairstyles that we were seeing. Bon Jovi, still an important artist today. And of course, these two gentlemen, Bob Hope, Jackie Gleason, sort of on the way down. Nancy and Ronnie reigned supreme. We were just in their presidential library a couple of weeks ago with the Halstead Society. And of course, Kareem and Magic, the Lakers here on the West Coast, were just dominant. And so, those were the days. But also in trauma systems development, Don Trunke had just published in Scientific American this very important piece of work on the trimodal distribution of death, and we were still absorbing the lessons from Vietnam as to the importance of trauma system development. And so Brent Eastman, who is in the audience today, was an important part of this driving force, and the papers that came out of San Diego County talking about that system development with Gail Cooper were very, very important lessons as we were learning about triage and transport, identification, triage, and transport of trauma victims to try to affect this trimodal distribution of death. I saw some fabulous, interesting work out of this department re-examining the trimodal distribution of death yesterday by one of the trauma faculty. something that really needs to be done as we begin to try to unravel this. And the question is there really the golden hour? Does that really exist? What better place for that to occur than here in San Diego County? So trauma systems began to emerge. To try to make the point before I move on to the trauma center, a case was presented yesterday in a young woman who had a shotgun blast to the torso with 2 aortic injuries, a pancreatic injury, a splenic injury, a hole in the stomach, and profound shock, who is now still alive on your service, on the trauma service, after the good work of Dr. Coimbra and his team. How can that happen? That patient got to your trauma center in 10 minutes or less. Very different than what I see in rural America, but here you have that advantage. And then once the patient got there, this was available to him. A rapid, organized, coordinated, carefully choreographed response with experienced people who knew what to do, when to do it, and how to do it, an operating room that was immediately available. Through the 1980s, the concept of the trauma center grew as well. A specialized hospital facility distinguished by immediate availability of specialized surgeons and the other members of the team that can provide care at a moment's notice. Now, we know clearly that if you look at stroke centers now and the outcomes in cardiovascular centers, the high requirements there, this very same approach now is being adopted by other disciplines for those time-sensitive diseases that need care. This evolved clearly through the 1980s. Central to it, the team dynamics. How do we work together in that moment? What are the ergonomics of resuscitation? How do we move around the bed? What are the roles and responsibilities in the moment? Does everybody know their job? Can you compress the care that's given into the briefest period of time to try to get to the point where you can begin to control the physiology? All of these developments, whether it's system development, center development, team dynamics, are about taking something which is out of control and putting it into control, and that is the physiology of the patient. And so I know for a fact here you do videotape review. We did them exhaustively at Penn, where we would look at our moves and try to save every minute. Maybe unnecessarily so, but it's what we did because it's what we thought was important to do. Because every minute lost is another minute of bleeding. Every extra minute of bleeding is an additional time of hypoperfusion. Every additional minute of hypoperfusion is a greater chance, if not for immediate death, for death at that third peak that Dr. Trunke talked about, multi-organ system failure, death later on from that slow death that occurs. Time being the key issue here, time to definitive care. Get to the operating room, stop the bleeding, get to the ICU, reverse the biochemical response. Limited understanding in the late 1980s, late 80s compared to what we have now in that cytokine response, that inflammatory response that occurs after an episode of hypoperfusion. So that was where our heads were. That was the environment that we were working in. And it began to become clear that there were centers that were developing that were specifically interested in this problem. Through that time, trauma fellowships, not exactly in their current form, but trauma fellowships began to emerge as well. And what my mentors were saying at the time was, this is an area that requires special focus. You're now trained as a general surgeon. You ought to know how to cut and sew. You ought to know the physiologic basis of surgical disease. But now there's the next step in learning advanced concepts of resuscitation. Bill Schwab, my mentor for so many years, said, and I was his first fellow, I'm not here to teach you how to operate. I'm here to learn how to think. And we started working on those concepts. And Bill was not alone in this. I mean, there were other people across the country who were developing similar centers. John Morris down at Vanderbilt. And this clearly isn't everybody. Tim Fabians, our soon-to-be president of the AAST. You can still see Bill pictured over here. If you look very carefully, there's some young high school kid here in that picture from the early fellowship, my early faculty days. And Tom Scalia, who was down at Kings County with Bernie Jaffe and others, all developing a singular focus as a team, a specialty trained team fellowship-trained teams ready to receive these patients out of the trauma system, into the trauma center, now onto the trauma service. And there were others, too, who were really vocal spokesmen for the specialty, also managing and thinking about the same problems that we were having. Dave Feliciano, Dave Richardson at Louisville, and of course, you know, the monolithic Ken Maddox, who has been an icon for trauma care for so many years. All of us in these centers were having the same experience. We were all seeing and understanding the same problem, that things had changed by the late 1980s in the sort of wounding patterns that we were seeing. In my own fellowship days, I can remember going to the literature to try to learn about what to do with the patient that I had just seen, who was shot 4 times and had 3 major vascular injuries, multiple visceral injuries, and I would go to the literature and find pretty much nothing. We were no longer seeing what was described in the literature, single-shot, low-caliber, low-velocity injuries. We were seeing this, rapid-firing weapons, semi-automatic weapons. They weren't high caliber, but they were higher caliber than certainly the Saturday night special, with a higher muzzle velocity. There was greater tissue destruction. There was more that needed to be managed. And if you just look here, this is from the CDC in 2001, and look and see the average number of trauma deaths, you can see that just from firearms alone during this period, here's 1990, there was a peak. Another factor had arisen. Another important change had occurred. Another driving force had manifested itself. In fact, this is work that, again, my former mentor Bill Schwab helped produce. If you just take a look at outcomes for all injuries versus firearm injuries, look at the disproportionately high number of deaths that occur as a result of firearms. And then, of course, Bill, in his presidential address at East, talked about the bullet as a pathogen and got great national attention as he was trying to work through the issues of prevention of death, preventing this from happening by increasing public awareness. It was true in Philadelphia as well, and unfortunately now in Philadelphia there's another upsurge. We saw a tremendous change over this 5-year period between 1985 and 1990 with an increase in semi-automatic weaponry. And most of the increase in deaths in Philadelphia County from firearms were accountable to semi-automatic weapons. That change, that singular change. Some of you who are old enough may remember in the press at that time across the country, people were talking about the fact that the police are now outgunned. The thugs are carrying greater weapons of greater destruction compared to the police. This table helps crystallize that, where you can see the number of deaths, 145 versus 324, all of them due to handguns, but a 50% increase, if you will, correction, 100% increase in semi-automatic weaponry. A real change, and in fact at the time, our patients on average had about 3 penetrations each. And you know what? Should be no surprise to you. They weren't really doing well. Patients were not surviving, despite the fact that trauma system development had occurred, trauma-centered development had occurred. There were groups of people with a singular focus on this problem. There was still that increase in violence. The only element that was missing was that frustration. And believe me, the frustration was growing. As I mentioned earlier, if you went to the literature at the time, 1989, this is Dave Feliciano's paper. He produced a lot of papers while he was at Baylor in Texas. Reported an 88% survivorship with abdominal gunshot wounds. Not so bad. But if you really dug into it, you saw that the patient population was different than what we were seeing, and that if you looked at those patients who had major vascular injuries, 80% of them died, and there was only a 60% overall survival in those patients. And if you dug in even deeper and looked at the patients who had more than one vascular injury and multiple visceral injuries, their survivorship was only about 10%. That's what we were seeing. We were seeing patient after patient after patient who died using sort of the traditional approach, where you do, as we discussed yesterday in conference, exploratory laparotomy, 4-quadrant packing, look at the central peritoneum, get initial control of bleeding, initial control of contamination, and then do all the operating that needs to be done. Operate until either you drop or the patient stops, whichever comes first. Get it all done. Complete the operation. But the reality of it is, at the end of that, it just didn't work. I can remember a couple of cases that always come to mind. In and around Christmas of 1991, there were only 4 of us on faculty there. We were doing 60 to 70% penetrating injury work. Call was from home. 70% penetrating, you're going to be operating every night, all night. It was over Christmas. Bill Schwab and I were on call every other night that week because we were trying to give the other 2 guys a little time to rest. We saw a tremendous amount of injury. We operated together a lot that week. And we had a patient who had a left thoracoabdominal trajectory. Took out the left lobe of the liver, stomach, tail of the pancreas, spleen, kidney. We did about 2 hours of flawless operating, got everything put back together, including the small bowel. I neglected to mention that. Did the distal pancreatectomy. Ended up, great operation, dead patient. I can tell you, I really don't believe that either of us, I was just had come off a massive operative experience at Jefferson. Bill was a very good technical surgeon. He and I worked together enough. We knew how to do the dance. There was none of this my case, your case. It was just the case, and we got it done. And when you end up in that situation, you realize that some of the things that you've been taught, having executed them as well as you just executed them, still having a dead patient probably isn't worth doing over and over again. It's an easy thing to defend at the M&M conference, but it's not a very good thing to explain to the family. And so the frustration clearly was there. As you saw there, Einstein would say that the definition of insanity is doing the same thing over and over again and expecting a different result. We needed to change something somewhere. And when we were sitting around talking about this amongst ourselves, we know that we had to do something different. A literature was slowly emerging on this, and if you dug back into it, you could see that the idea of not trying to complete an operation was not exactly new. You can find remnants of it going way back. Harlan Stone in '83, but we're talking 10, 15 years earlier than that. Even Lucas and Ledgerwood talked about it. And you can see these reports that started to emerge about doing some kind of a staged celiotomy and describing this thing called abdominal compartment syndrome and trying to find a way through it. This was a really important little paper that was presented by Scalia's group at the East meeting in 1991. Because after it, a bunch of us gathered out in the hallway and we started sharing our naughty little secrets. We started saying, you know what? Let me tell you what I did last week. I had these 2 ends of, they had this guy whose intestines were blown apart and his aorta was injured. I fixed the aorta. I meatballed everything shut. I left the leaking pancreas in there, and then I went to the ICU and fixed them and went back in 2 days. Has anyone else done something like that? We started talking about that. We were afraid to really talk about it in our own departments, many of us, because it was surgical heresy. It was not what you were taught to do. You just weren't supposed to do that. I can't tell you how concerned I was as a junior faculty when we started trying to truncate operations. And Ernie Rosado, who was the brother of my chairman, was in my department. And I went to him after the first time I did it. I almost confessed my sins. It's that Catholic thing in me. Dr. Rosado, let me tell you what I did. To talk to him, to talk to somebody about this as well as my partners as we began to try to find ways to truncate the operation. Clearly in blunt injury, there were a lot of papers that were out there that talked about packing the liver and stopping. And there seemed to be some efficacy. None of the papers, frankly, honestly, none of any of it that any of us have ever written has been great science. But there was a bunch that was written about it, to talk about it. And it seemed to make sense that in penetrating injury, we had to do something different. The problem here was this rapid physiologic decline that occurs. The patient who gets to you 10 minutes later after Philadelphia Fire Rescue brings them to you, they're awake, alert, and they're talking. And then within about 35 to 40 minutes, you're in the operating room and their blood pressure is 40 as you're trying to control their bleeding. Different than what you see in the rural setting, but this rapid physiologic decline. And this is just a schematic to try to make the point. This question now being asked at this institution through the data review of deaths here in San Diego County. Is there really a golden hour? In some patients, I don't think you have a golden 15 minutes. In other patients, you may have a golden 4 hours, and that's one of the things that needs to be still unraveled over time. So, in those early days at the University of Pennsylvania, those pre-hospital times were very, very short. And we used to refer to those patients, in essence, as the walking dead. Because of the fact, before we started talking about damage control, we were, as a group of young faculty members, part of the television generation, and that seemed to be sort of a cool thing to call them. And we started working out these steps as a group with those other centers across the country. We were all talking about this. I frequently had discussions with John Morris, and of course with my colleagues at Penn in the Division of Trauma, and with Dave Feliciano and others about this, where we talked about doing these sorts of operations in 3 steps. We would first start by controlling hemorrhage in the simplest of way, controlling contamination, do the packing, and then close it somehow, some way. And we made lots of mistakes as to how we did that early on. I'll talk a little about that. Then go to the ICU and be an intensivist. Sit by the bedside, don't leave. Do what you know how to do to restore physiology. John Morris used to call it the secondary resuscitation, where you're trying to get the patient warm, clear their acidosis, not coagulopathic, and get them looking as good as they can physiologically in preparation for return to the operating room. And then go back and do a definitive reconstruction. And that was something we started to call damage control. Now, the story behind the story, as I see it, one man's perspective, Bill Schwab was sort of a running mate of Steve Shackford. I mean, they were in Navy in and around each other at the same time. And this term, comes from the Navy, damage control. But those of us who were younger faculty remember it from an old television show called Journey to the Bottom of the Sea. And in Journey to the Bottom of the Sea, probably maybe you've never even seen that or heard of it, there was always, the submarine was always on a mission, and it always got into some kind of a crash. Some kind of a major catastrophe, and then there was always a report from damage control. And so at the helm, the characters in the television series would get the report from damage control. And so we started talking about doing damage control on these patients and temporizing them in some way. And the name seemed to stick. And though I will tell you that it came out, the name came out of our institution. It wasn't long before it was widely accepted, but the concept was sort of out there floating. Ideas are free. They need to be reeled in. They need to be organized, and they need to be translated and then communicated in some way. The John Ray Barton Surgical Associates was the old guard in the Department of Surgery at the University of Pennsylvania. And I can tell you that at our M&M conferences early on, it was a bloodbath of a different kind. If you can imagine, these are just direct descendants of I.S. Ravden and Rhodes. And we were breaking with traditional approach. To do a GI anastomosis 48 hours after injury in the face of a 60-liter resuscitation, and even have the nerve to think that it's going to work. It was completely against everything that we had been taught, at least that I had been taught. And those meetings were tough. They were not contentious, but they were tense, to say the least. And the criticism was, there was a strafing that had gone on, despite the fact that we had done our best to try to objectify this in a paper and present it to the AAST, and talk about trading all of those complications that we expected to get for survival. And that was really the trade-off. Look, I'm going to try some new things, and we're going to try to get this to work, because the patient's going to die anyway if we don't. And if I get him to survive, we'll see if we can deal with the complications. It wasn't even, I'll deal with the complications. It was, we'll see if we can deal with the complications and understand them in some way. The national response was also not always positive. Most people sort of stood in the back of the room, and I still hear it today, if only those damn trauma surgeons knew how to operate, they wouldn't be doing this. And the leaders, some of whom I put up on the board, were speaking out in favor of this. And this was important, to have senior leadership be willing to listen to what others were saying and endorse it. My favorite, of course, is J. David Richardson, who sort of has a way with words. as you can see in that quote, who really was starting to embrace this. They were doing it at Louisville. They were doing it in New York City. This is Leon Pachter, who was probably one of the finest liver surgeons ever to practice, and can really do a definitive liver operation on anybody at any time under almost any circumstances, which many of us can't do. And of course, Ken Maddox, very much the spiritual leader. And the data started to say, well, maybe there is a difference. Maybe there is a difference when you're doing it in hepatic injury and in. And we started to try to put, and this is a much more recent review, started to try to gather up the information as this was evolving through the 90s to show that there was a survival advantage. And by virtually every way that we looked at it, we thought there was a survival advantage. Over the ensuing time frame, there was wide adoption of this over the last 10 years. And a lot of other things occurred as a result of now having a group of patients who survived, who we are fairly certain otherwise would not have been alive. So let's go back to our analogy with the French Revolution. This is Newton as the divine geometer by William Blake in 1795, where this began to talk about the rise of the Age of Enlightenment. A number of changes occurred in France in 1789 and the ensuing decades as a result of the French Revolution. There were other corollary effects after that significant change occurred. And some of them are listed here. It was the death of feudalism. The whole entire land ownership method or system changed dramatically. There was a new social order, the Code of Napoleon, Declaration of the Rights of Man. The power of the state was enhanced throughout Europe, and it was the Age of Enlightenment. Ethics, aesthetics, knowledge came as a result of the revolution in this period of enlightenment, this period of rejuvenation, when vitality or freshness is restored. I think some could say in retrospect, as a result of this singular change in approach, in many ways trauma surgery was rejuvenated in that there were other options for patients who otherwise were destined to death. What are some of those corollaries? What are some of those things that developed? Well, the evolution of the use of temporary shunts came about. I can tell you, I can remember the first time I did it. I was crazy enough probably to be the first one to do it at Penn. John Weigelt happened to be visiting professor at the time. And I sort of staggered into Bill Schwab's office, unshaven at 8:30 in the morning after a full night of operating, having put in a shunt in a femoral artery in a patient who had multiple gunshot wounds. Dissected out both ends, put in some IV tubing, and said, well, I normally would be ligating this to get this patient off the table. What does he or I have to lose? We're going to put a piece of plastic in there and see what happens. And lo and behold, it stayed open. We went back at 24 hours, reconstructed it, saved the extremity, and then shortly after that did the first one in the superior mesenteric artery and reported that in the literature. So the concept of temporary vascular shunting came out of this as a damage control technique. Again, just an example of what that might be able to look like, but you can really use just about anything. The key is to try to get the two ends, find the two ends that have been blown apart and have retracted back into the tissues, get some sense of control, and then carefully put in the shunt without losing a tremendous amount of blood or creating additional damage to the vessels. Other things, besides the temporary use of intravascular shunts, avoidance of enterostomies. In my training, in a bad situation in the abdomen, everything got tubed and diverted. Now we're talking about not tubing and not diverting, because every time you create an enterotomy of one form or another, you're destined for a problem in a damage control patient, particularly if you're bringing out a stoma through an anterior abdominal wall that is thick with edema. Whose geometry is going to change dramatically over the next couple of weeks, leading to stoma retractions and all kinds of problems. So we stopped putting tubes and stomas in. Less is more. Less operating better than more operating. The delay of definitive GI reconstruction showing actually a lower complication rate from GI problems as would be otherwise predicted by the penetrating abdominal trauma index. So these delayed reconstructions, and then judicious use of the planned ventral hernia. Leaving the abdomen open so that you don't suffer the consequences of abdominal compartment syndrome. And then there was another series of changes that were going on. Laura Nelson, Joe Civetta, a number of other people, the rise of aggressive surgical critical care. And who better than to determine adequate endpoints of resuscitation than on these damage control patients? We saw all of these things begin to rise. Oximetric-driven volume resuscitation came up through the 80s with Shoemaker, using RV EDVI catheters out of Orlando and Vanderbilt, then Orlando. New methods for core rewarming, better understanding of inotropic support, new modes of mechanical ventilation, a technique that didn't catch on really, intramucosal pH monitoring, but pointing to the fact that new ways to measure endpoints of resuscitation began to emerge, and of course ways to understand abdominal compartment syndrome, which came into being and its definition was created, in essence. A markedly increase in intra-abdominal pressure, being intra-abdominal hypertension, and if you have the pressure-related regional blood flow disturbances that are associated with it, that is the elevated pressure plus the systemic manifestations, now you have the syndrome. And we were identifying this very late in the course. I mean, at the end of my training in 1989, there wasn't an abdomen that I couldn't get together with brute force. I can remember thinking back even in my residency training program of patients who had abdominal aortic aneurysm, rupture, repair, who would be getting massive fluid resuscitation at the bedside, and you go up their abdomen and sort of like that. And you'd go, well, there you have it. And we would watch them die. That would be it. So to leave this thing open, this big hole in there, was not a comfortable thing. And these patients had, with the volume resuscitation we were giving them, tremendous amount of intestinal edema. And Rao Ivaturi helped work out with the collaboration with the bariatric surgeons, this physiology of intra-abdominal hypertension, which is a perfect ischemia reperfusion cycle in essence, where you resuscitate the patient up and begin to get intestinal edema and end organ edema, and you begin to see ischemia occur, perfusion goes down, you resuscitate them up, and as they swell, they get more ischemic. You're in this perfect ischemia reperfusion cycle, and there's a couple of different ways that can happen, either from edema or you can get it from ongoing bleeding. This beatitude, which is what I call it, something to keep it's a way to think about it, emerged as well. Mid-90s with John Birch, talking about the different grades. It's easy to remember, 1, 2, 3, 4, 10, 20, 30, 40. And at least one approach that if they have low-grade intra-abdominal hypertension, you do a normal valvulic resuscitation. If they're moderate, they get a higher volume resus. At some point, you need to open them up in the ICU and some point in the operating room. And this is really a local practice pattern and can't really be stated as dogma, but at least as a guide that you can think about what you're going to do in this situation. And again, really, this applies to even patients who have not had abdominal surgery and have so-called secondary abdominal compartment syndrome. If in this period in the 90s, literature emerged, data on all of this, relative to all of these changes relative to abdominal compartment syndrome. I mean, it became clear that literally every physiologic system was affected by virtue of the fact that there was a change in perfusion in the abdomen. And you can literally find references on each one of these. I've gone through them and cataloged them, and there are many more. So clearly it was a real live entity. This is Sherry Meldrum's work looking at grade of abdominal compartment syndrome and organ dysfunction. And of course, as grade increases, problems with urine output, peak inspiratory pressure, systemic vascular resistance, and oxygen delivery and consumption all occur if over the spectrum of increase in abdominal pressure. So a response had to occur, and the response was new ways to manage this wound, this devastating abdominal wound. This is an incision, a wound that we create that now can't be closed, that's prone to fistula and all kinds of problems. And so new methods evolved in order to manage that, the so-called vac pack technique, the homemade vac. And there's a company now that's become a billion-dollar company as a result of it, right? KCI, working with the basic scientists at Wake Forest. They've now become a billion-dollar company, and really with two products. They have surfaces, kinetic beds, and they have the VAC. Anybody here using the VAC? Any non-trauma surgeons using the VAC? We're all using the VAC. Stimulates granulation tissue, and clearly with judicious management of the intestines, using natural tissue, the omentum, using non-abrasive surfaces, being respectful of the serosa, you can reduce your fistula rate now in some reports less than 5%. But this is how we did it in the early days. Well, why do we do it that way? Because it was a miserable thing to manage in the ICU. And there was edema fluid and blood all over the floor. And so we began using homemade stuff, right? An iobam dressing, just Curlex, put in a piece of plastic underneath this, some Jackson Pratt drains, and hence the VAC pack. And now the VAC has evolved to a point where people are talking about it to use it in some way for earlier closure. When you have enough failure for these patients early on, when you're aggressively trying to close the abdomen, as we were in the early 90s, and then having catastrophes occur as a result of that, we evolved to a point where we're leaving them all open, which was good for its time. I don't think it's good anymore, but I think it was good for its time because we needed to define that we could get survivors out of this and do the reconstructions later. 1991 did the first one of these, leafing through the European literature. Right? It came out of Europe, the component separation technique. Everyone said, don't touch that. And I'm not sure ultimately why we did, other than the fact that the patients were miserable. Because this is an elective operation, really fraught with complications at the time. But now, again, we understand this greatly. Number one, we understand how difficult it is. We understand how good results you can get. We also understand how important it is to prevent this now. Because in the early days, we were willing to accept this. Remember trading survival for complications? Well, now the ante has to go up. We have to find ways not just to, we now know we can decrease mortality. Now we have to find a way to decrease morbidity as well. And I think that's happening nationally. You can find applications for this, and I heard earlier that you've at some point or another talked about all of this. I can remember getting a call from a vascular surgeon from Riverside Hospital in Delaware. And he called me to tell me that, I didn't know him, had never met him. He said, well, let me tell you what I did last night. And every time I hear that, I start to pay attention. This was in early mid-90s, I can't remember exactly. He said, I had a patient who came into my emergency department. He was a vascular surgeon who had a ruptured abdominal aortic aneurysm. I brought the patient to the operating room. Her blood pressure was 40. She was clearly exsanguinated. I opened the aneurysm sac. I got proximal control, opened the aneurysm sac. I took a chest tube and I put it down from the proximal aorta down her left lower extremity, and I ligated her right lower extremity. I went to the ICU and I sat there and I resuscitated her for 8 hours, and I brought her back and reconstructed her. What do you think? Called me to tell me he did this. The lady survived. So people were starting to try to use it in other applications, and though we don't really have data, I haven't seen any usable data, I think that clearly there are other applications for this. And now you can see this in every major surgical text. There have been numerous international symposiums, and what really helped solidify it for me were a couple of things. One is when it became a scenario on the American Board of Surgery oral examination with a liver injury, and the other quite recently. Because when you see this kind of thing, it does affect you. This is current information management in Iraq today, where this wounded personnel has had damage control with a big retroperitoneal hematoma, 10 lap pads, and the skin only is closed. And it's clearly from the spring of this year at a symposium at the Uniformed Services, we're going to see information that's going to come out from the current conflict in Iraq, which again categorizes and indexes to the next level the applicability of this technique and the corollary techniques that have come from it in major military conflict. So my thesis that the damage control has been, in essence, was a revolutionary break that was influenced by a whole variety of factors and rose up from a whole number of investigators that was a departure from mainstream surgery and really led to the rejuvenation in many ways of injured patients and the development of a whole other series of techniques. I want to thank you for listening to that story. I'll be happy to hear your reflections and any questions. And again, my sincere thanks for your hospitality.